Good evening, everyone. Welcome to our bariatric surgery webinar. My name is Angie Bunkley. I'm the bariatric surgery program coordinator for Tallahassee Memorial Healthcare. We are so glad that you could join us tonight. You're also going to hear from Mr. Greg Laffitte. He is a PA with our bariatric program, and also our bariatric surgeon, Dr. James Parker. Before we get started, just a quick reminder, we're going to have all participants muted just to minimize background noise. If you have any questions, please use the Q&A feature. We're going to have plenty of time set aside to answer all your questions. And also, as a little thank you for joining us, a random attendee will be selected to receive a Publix gift card, and we'll notify you via email after the session. So with that being said, I'm going to let Mr. Greg go ahead and get started.
Thank you, Vera, for the handoff, Angie. Well, good evening, everybody. Glad you guys are here with us. I always look forward to getting to participate in these seminars that we offer because it gives me a chance to speak to people directly about the advantages of bariatric surgery. But before I start flipping through some slides, I want to take a moment and kind of reflect for each of you tonight. And if you've got a family member that's in another room, you ought to bring them over tonight to let them hear what we're going to discuss. Let's talk about bariatric surgery in just a moment, but more importantly, why you are here tonight is that you're obviously concerned about your health. Bariatric surgery can alleviate so many significant problems, and we get rid of problems. What does that mean? What's the translation? Why are we having this conversation tonight? Because our goal is to create the environment for you such that you'll be able to live your years, the older that you get, excuse me, with a degree of independence and freedom and happiness. So keep in mind, that's why we're having this conversation. And I'm going to go into the details as we approach bariatric surgery of what we need to do to be able to be successful to get started, basically, and then how to have long-term success. What's really important, I think, is if you look at your calendar tonight, if you were designed or thinking that this is what you wanted to pursue, there's a very strong likelihood that we could have you in the operating room in 4 months. And there's a very strong possibility that a year from, say, today, you would not recognize yourself due to the success that's been achieved with healthy weight loss. All right, my voice is a little gravelly tonight, so I'm drinking a spot of tea, so bear with me as I try to keep from coughing. So here we go. A lot of information. You guys can read the slides as well as I can, so I'm not going to sit on these slides very, very long. We're going to move forward, and we're going to get into the weeds of this. Okay. So there's a team that takes care of you guys when you come out here. It's a specialized team. It's a very caring team. It's made up of some people that have a passion for helping people realize success. Bariatrician, that's a term that's designed to basically infer someone that practices medicine with weight loss being that principal focus. That's me. We have Brandy here, one of our nurse practitioners. She's not here tonight. But you've got a very dedicated team of people that are very interested in helping you realize your full potential. Dietitian, goes without saying, all of this does not succeed unless we bring very qualified, competent dietitians on board. And we got a young lady by the name of Ann that is absolutely fantastic, extremely fantastic. We've got a behavioral therapist that we send people to be able to get into some of the discussion about behaviors that are very important for long-term success. We have an exercise physiologist that if you've not met this gal, Christine, that is somebody you should meet. And remember, we are discussing tonight the concept of an environment to help you get more healthy. And these pieces come together with behavior that's appropriate. It's the mindset of what sort of dietary concerns do I need to start paying attention to. Exercise is a big deal. And remember that the obesity component, excuse me, probably snuck up on you before you could even pick it out and go, oh, I need to do something about this. And of course, at the bottom of the page here, the bariatric surgeons are there. All right. This is the I Love Me slide. This is what I do. I specialize in treating obesity and the obesity-related diseases that everybody ends up facing over time. It's a very compelling statement for me to say to everybody listening tonight that it's not just what you see standing on the scales. It's not just what you see in the mirror. It's about how you feel. Then the emergence of, well, now I'm having to have a CPAP device. I'm taking diabetic medications. I might have a cholesterol problem. I might even have a hypertensive problem. And more important, You may be someone that's been trying to lose weight for years and you've had no success. That's why you're here tonight. We provide, if you would, the medical, the non-surgical weight management. Tonight's focus is primarily going to be going after surgical, but the idea here is to identify those things in your environment to help you be successful. That's my purpose for doing this. I love it. It's a calling. I have a fun time with it. There's me on the bottom left over there. Brandy is the nurse practitioner I talked about, and she's one of our dietitians. And we've also got a medical director on board as well. There we go. Christine, exercise physiologist. All right, everybody. I'm not suggesting that we want to go out tomorrow morning and put on a 50-pound ruck and go hike 5 miles. We're not looking to do that. What we're looking to do is to get you up moving to your capacity, doing the kinds of exercises that you would maybe have not, I don't know, you could even look at yourself and say, when's the last time you went out and actually did some exercising? And the answer may be, it's been a while. And the answer for that would be because you've gotten out of shape or you're deconditioned. Pardon me. Christine is a very capable, very affable person for you to be able to speak with, and she can design a program for you in the beginning stage of this and will advance that over time. I'm going to deflect to the point to suggest that if you've not met an actual exercise physiologist, you're really missing out on the opportunities that you could take advantage of to have this long-term success. We're not looking for you to be that person that hits what I call the terminal decade, living in a nursing home, sitting in a wheelchair. People don't come to visit you. You've lost the capacity to go see your grandkids. You might have lost the capacity to even to travel. So there's a number of reasons that this support team can come together and create this environment that I so desperately want to provide. And dietitian. If you heard the discussion of who the experts are, this is the page that's got them. They're the proverbial burning bushes to be able to help you achieve the long-term success we're hoping to. And I'm not suggesting we want to lose weight for next year. I'm talking about losing weight next year, have an evaluation, and continue this relationship for many, many, many years to come. It's extremely important. Moving on with this, Dr. Gerard's copy of his picture's up in the left corner for you. Dr. Parker's over here. He's going to take the helm in a few minutes. Excuse me. Megan Bell, PA over there that works with Dr. Gerard, and Courtney with Dr. Parker. Yeah. Excuse me. And by the way, this isn't COVID, so we're okay. Angie started the show tonight. Angie is the big time program coordinator. None of this comes together were it not the fact that the professional talents that Angie Bunkley has. It's always a joy to deal with her. You will find nobody more friendly, more helpful, more willing to take on the concerns that you have. She's the gal to do that. And Sam Smith over there, this is the right-hand man for Angie, where we gather data. We put information together on spreadsheets to be able to help us have a better program. So it's not a stagnant. This is always moving forward, looking for new techniques and ways to be able to help people out. I'm going to slow down here just for a moment. We're sitting here tonight. We're having a conversation about getting healthy. And I would love to take this to a PhD level and talk about it for 8 years, but I don't believe people are going to hang out that long to let me talk about it. So we're going to limit this in the scope of the conversation today to some very, very specific bullet points that you can see on the slide. The evaluation of metabolic or medical causes of obesity is something that I really, really like to figure out. I love the conversation that says, how old, when you were 8 years old, where'd you grow up? What was your family life like? What was the behavior at the kitchen table? What was the diet that you typically consumed? Or maybe you grew up in a very, very challenging financial circumstance where food, because it was expensive, you may not have had food and the quality that you would like to have had over all the years. So we get into those questions because they're important. Eating disorders, it's a huge one. We like to understand that sometimes people have some behaviors that they exhibit today because of some of the hardships they endured as children. Oh, I thought I could fix this by drinking tea tonight. We're going to take a look at medications. The electric systems that we have for electronic healthcare record surveys, it gives me the opportunity to pull a few pages back and to see if there's been a history of a particular medication that you could even identify as going, I really didn't gain weight, and still I started doing X, Y, or Z. finding out these things oftentimes helps patients feel a little bit better because they think to themselves, well, I've done what I was supposed to do, but there's something that's in place that's worked completely against it. So it's extremely important that we basically open the book up to find out as much as we can about that journey that you've been on. Deficiencies, I want to work with that. Do a lot of lab work. You're going to be going over to LabCorp Quest, and we're going to be analyzing you, if you would, things that possibly might be a little bit out of normal ranges. And besides that, when we go to surgery, we certainly want to have up-to-date labs before they take you to the OR. Behavior modification strategies. That's one of probably the most important, if not the most important, one of the very important concepts to go through. And that is to say, when I go home tonight, am I going to go raid the refrigerator? Am I going to go into a cabinet and start eating things mindlessly? Our job is to help you recognize these things. And it's not shaming. It's not to be judgmental. It's not to give you a hard time, but it's to help create that environment so that you can have long-term success. And as I mentioned to begin with on this is not necessarily what we want to see on the scale. It is important, of course, but there's more to it. And when we do have this weight loss, I'm going to do an actual body composition assessment, and we're going to show you this is how your body's put together. A certain amount of this is going to be water, a certain amount is going to be fat, some's going to be muscle. We want to make sure that when we go down this path, that we're making the changes that are healthy. I like the idea of somebody that says, I have not gone for a walk more than 5 or 10 minutes over the past 20 years. A year after your surgery, you'll probably be able to go out and do some of the local runs around town. You would be amazed. Nutrition, of course, dietitian is going to really drive that home. We're going to really spend some time enforcing how after surgery, there's behaviors that you need to start doing. I don't think I'm being mean to say that oftentimes people will turn a blind eye to the things that are harming them the most. It's even a fair statement to say that this snuck up on you. It's a fair assessment to say, I got married, I got a family going, I've had my career, I've had all of these things within my life. So somehow I got put on the back burner and I stopped taking care of myself, taking care of other people. It's not a day goes by in this clinic that someone will tell me, I used to be very, very active, but my parents got older. And so in order to take care of them, I stopped taking care of myself. All of these concepts come together and they create that environment so that we can have that long-term success. I want to optimize. I want you to get to your goal. We want to get to that place where your independence is not going to be compromised. And you get to say, yeah, let me see, I'm 50 years old today. My oldest is going to be 18 by the time I'm 65. They're going to get married and maybe have some grandkids. I want you at 80 years of age not to be sitting somewhere in an assisted living facility and dealing with some problems that are just really not enjoyable. All right. Going to help you stay accountable. That's my job. Brandy's much nicer than I am. I've got a great big Neanderthal head. My voice, when I'm not having a cold, is a little bit more baritone. But I want accountability. We want to help you make decisions so that the long-term process gives you what you're hoping for. I have plenty of people. We've got folks that are posted on YouTube that have done tremendous, maintain their muscle, out exercising the likes of which they haven't done in 20 years. And all of that can be possible after the surgery that we're going to go through. Lab work, of course, we're doing on a regular basis to keep you up to speed. All right. It's a busy slide, but it's well worth taking some time on. Obesity, it's not just because I don't like how I look when I wear my overalls. It's not because I don't like the way I look in front of the mirror, or maybe I've become conscientious of my physical appearance. The thing behind this is that this is characterized by this buildup of adipose tissue that leads to all sorts of problems. Causes might be genetic. Some of it's going to be behavioral. There may be even some environmental factors out there. But take a look on the right-hand side there. You can see the causes. You can see the symptoms. Some of these things may be relative to you. Some of these you may look at and go, oh, yeah, I see exactly that's where this is. So I'm going to focus in on one. How about the age factor? I've had people that have had gastric surgery as old as 82 years of age. One very lovely lady was not able to go out and enjoy traveling, high school reunions with some of her girlfriends. She lost a tremendous amount of weight through a bariatric surgery. And I think even this evening, she's on a cruise ship out in the Bahamas someplace. So we see some very, very unique things that can be accomplished and can be changed for you by approaching this bariatric surgery and letting this team create this environment so you can have this long-term overwhelming success. And I see it on a regular basis. It's actually kind of striking. BMI, I'll hold this up. When you come to the office, we're going to be weighing you. When we get the weight, we print off a small receipt type paper that shows your body composition. And we get to have a conversation about some goal setting. The idea is having a clear understanding of where you are, coming up with a very clear plan about where we want to go. And so what's important about this, I don't want, anytime you come into this environment here, you're not going to have somebody look at you and say, oh, that obesity that you have, that's all your fault. How many times have I heard young ladies, and there have been a number of occasions where someone will get very teary-eyed because when I begin to probe in a respectful manner, what was it like growing up? You would be surprised the number of young girls that had some very dysfunctional relationships that were thrust on them, abuse, I'll leave it at that, and how their life developed, and then some specific behaviors became part of what they did on a regular basis. We don't want you to walk away as if you've been shamed or abused. We want to help teach you quite the opposite to behind that. So, and in the past, there have been those circumstances out there. Well, diet and exercise, that was the only way you could do it. Weight loss surgery was viewed as dangerous. I still hear people say that. And they'll raise objections. And I understand people can have objections, but you need to understand something. How do we get you if diets have not done anything? If medications, you're afraid to take them? Or what if you lose some weight and then the weight comes right back again? There's not a day goes by that I don't get a young gal that's come through here, say in her mid-40s, she says, I look just like my mom. I've gone through menopause. I've tried every diet that's out there under the sun, and my weight won't come off. That's the circumstance where bariatric surgery trumps everything. Look at the bottom of the sheet here. Obesity is a disease and it's a cause. I cannot overemphasize that. We get rid of this disease, a lot of bad problems go away. Diabetes, I've seen that disappear. High blood pressure goes away. Do I see cholesterol values improve? Absolutely. How about obstructive sleep apnea? Gone. What about this one? They're happier. They're enjoying what they're doing in their lives and they find themselves more active. And then I hear people say, well, I've just retired from the state, gone into drop, and now they're traveling out to the west to go see the Grand Canyon. We do a pretty good job of helping you understand what you've got, how perhaps it came here, and then what the presentation is going to be able to go further for you. I mentioned earlier, think about a gland in your body. Most people think about tonsils. That's a gland. Well, the adipose tissue, what's around your waist, it's an endocrine organ. And if we were to go into, and I get excited about this stuff, so we could talk for hours about it. But what's dangerous about this, and please hear me, what's dangerous about obesity is that tissue actually secretes hormones. All right? It secretes hormones. How many people do we know are on Ozempic or Wegovy, Zepbound, Mounjaro, the list goes on. There are a number of people that will use those medications and they get some really, really good results with it. We're using hormones to regulate other hormones. In the body here, the adipose tissue creates hormones that are damaging, inflammatory, if you will, and they lead to things like heart attacks and the strokes. You can read the list. That's why we're talking about keeping you out of a nursing home, maintaining your independence, keeping a smile on your face. And when somebody across the country says, hey, come visit for Thanksgiving, you get on the phone, you make reservations, and you go do that. You're not going to be prohibited because your body is holding you hostage. All right. Factors that are associated with this. All right. Genetics can play a role, but you cannot pick your parents. So you have to consider something that maybe the genetics predisposes this, but it's the behavior that you choose. It's the behavior that you choose that possibly may start these gears turning to create this. If I know for a fact that cigarettes cause lung cancer, I need to stop. If I know for a fact that eating fast food causes high cholesterol, I need to stop doing that. If in your family there's a predisposition for these things, it's my job to point that out, quote, hold you accountable, make you feel better about it, and get you to that place where a year from now you won't recognize yourself. So genetic makeup's a big deal. Ethnicity is a big deal. That has to do with, well, you live where? What did you guys have? Well, let me just give you a good example. My daughter went to PA school up in West Virginia, and there was an establishment up there near the college where she was that had biscuits for sale, morning biscuits. They were the size of a dinner plate. And if you go look at the statistics about some of the folks that live up in West Virginia, diabetes and or many metabolic diseases, they top the list based upon ethnicity, how you grew up, what you did, and the behaviors that you participated in. Medical causes out there, diseases, hormonal influences, so on. Lack of activity. The number one thing, and I don't believe I'd get any argument out of this, the number one reason why people put on weight, number one, lack of activity. Lack of physical activity. So we marriage up expectations that are reasonable, start getting you more active, get very, very smart with your dietary intake, increase your protein, watch your carbs, keep a journal. If you kept a journal starting tonight, the moment we get done here, if you took a journal and you started writing down everything that you eat, and I don't mean, let's don't get into the weeds about the carbs and the proteins, just write down what you eat. And I had a gal last month, and she wasn't keeping a logbook for us. You got to do a logbook. I don't know what to correct if I don't see what needs to be corrected. And so she came and she saw me. She says, well, I'm ready to go to surgery. She goes, not so fast. Show me your logbook. She hadn't done it. So I gave her 4 more weeks to do a logbook one more time. She came in and in that 4 weeks lost 12 pounds, mostly because turned a blind eye to what she was doing and was not aware of the impact of the choices that she was making. And now she's, I think, going to the operating room next week. Physical activity is a big deal. Cannot overemphasize that. Y'all can read the rest of this. These are the things that should keep you awake at night so that in the morning you get up and the first thing you do is you call up to the hospital and say, hey, I just heard from Dr. Parker because he's going to talk to you here in a few minutes. I need to get on his list to come and see him. Dr. Parker, one hell of a capable surgeon, can put you in that position so a year from now, we're going to defeat this entire list of stuff that's in front of you. And these things are serious, y'all. Cardiovascular disease, look at that. Deficiency, sleep apnea, eating disorders. Each of these things, when we begin to lose that healthy weight, and oh, by the way, I was doing some reading earlier this afternoon, that the weight loss that we can see from a gastric surgery, and these are going to be some averages. If you're 100 pounds overweight, typically speaking, we can get 70 pounds of that off. If we go into some of the injectable meds out there, if we're lucky, we might get 17 pounds off. And the moment that you stop taking that drug, guess what's going to happen? Can anybody say it's going to come back? Yeah, I thought I heard that. So obesity is a very, 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 very mean. It's an aggressive, it's a gremlin. It's something that hides. It's something that makes you turn a blind eye to it. It's making these problems that, gosh, I didn't know I had turned into this. I'll even ask you right this moment. Look at this list and say, if I had the opportunity to turn this all around, would I take it? And the answer is, you should. Obesity is it's an epidemic. The numbers are alarming. And if you don't believe that, go to any outside event where families are there with their kids. And now we're beginning to see even the children demonstrate the same patterns of behavior. And it's much better if we catch this early before it's too late. That's probably an old number right there. Okay. This is my moneymaker. This is where tonight you can make a major decision. Because tomorrow morning we're going to open up at 7. Adult patient, overweight, obesity, and I'm assuming because you're here tonight, you have some concerns over this. Why do I get paid? I'm going to improve your health. That's a given. I'm going to improve your quality of life. Oh, yeah. Improve your body weight and your composition. Those three. And I see that every time someone has a gastric surgery, we achieve those. And people will always come back in and say, thank God I finally made that decision to become very active in moving in the direction of the health that I would like to have. We don't want to get into this terminal decade. Just say, for example, you find yourself possibly in the age of 65. The number one threat, the number one risk factor to a 65-year-old male, female is a fall. If you've lost your core strength and you trip over the sidewalk and you fall, you might put your hand out if you're lucky to break the fall. You just broke the wrist, which makes you then fall and hit your shoulder. Now you broke your shoulder. Then you fit your head. Next thing you know, you just got a ride to the emergency room. You just got admitted. What if you had a head bleed? We lose weight, we get you stronger, we build back some range of motion. We can hide from those potential pitfalls. So these goals, and tomorrow morning, again, we're going to open up at 7, so get on the phone calls. GLP-1s. I know there's probably a lot of argument for and against. And what I want to say about this is going to be based upon my own clinical practice. I'm not going to say things based upon what someone told me to say or what I've read in a magazine. And maybe you all that might have been watching the news today noticed Eli Lilly had a press conference in the White House. And so there's been some big deal there to be able to get a price cut on these drugs. Every time I've seen somebody on a GLP-1 discontinue the medication, the weight comes back. Every time, without exception. When I see someone that has a bariatric surgery, 5 years, people do extremely well. There will be some people that underestimate the responsibility that they have. You still have to be active in taking care of yourself. The GLP-1 drugs, they certainly have their place. From a diabetic management, yes, absolutely. If we are at a particular weight where your surgeon might like you to get a certain amount of weight off before the surgery, if I can get it covered, I'm going to write that for you. But they don't come just free of particular problems. One of the things I think is extremely important is to say, if I'm going to get my medical care from someone, are they going to pass this off as the perfect answer and solution for weight loss? I'm not doing that. I'll break open the package insert and I'll let you read line by line what we would be doing with this. Do they have their place? Yes, but they need to be used appropriately and they have to be managed. You don't just get that drug and go away and I never see you again. I've got some protocols that I want to follow about you checking with a dietitian on a regular basis. We look for some actual goals. I look for body composition. I want to see a diary that says, yes, you're now lifting weights. I want to see a diary that says, yes, you've started to follow what the dietitian has expected you to do. We don't use these in a vacuum. My experience, far better weight loss long-term with a bariatric surgery than what I witnessed with these GLP-1s. Now, skip ahead to that number there, 70%. Now, this is interesting. Follow me on this math, if you would. I'll take, when you come in and you see me, and I'm going to use a BMI calculator. There are many ways that we can come up with calculations about how much you are overweight. This is one. And I can tell you very quickly, within about 5, maybe 10 minutes, I've got the world's biggest calculator. And if my fingers hit it just right, it works. But what we do is we say, okay, this is the weight that would be ideal. Here's the weight where you are. I subtract that number out. And let's just say, for example, that's what we call 100 pounds excess weight. Bariatric surgery, nearly 99.9% of the time, will hit at least 70% of that. And if you continue to change your lifestyle, if you start lifting weights, if we start walking, if we try to get 30 minutes of good exercise a day, if you begin to be judicious on focusing on protein, I don't mean 1.2 grams per kilogram. I'm talking about, let's take this up to 1.5 or maybe even 2. If you've got a trainer, if you have somebody in your family that supports what you're doing, not sabotaging, you bring all these forces to bear with what a bariatric surgery can do for you, you can exceed that 70%. And I see it routinely. Now, are you a candidate? We're getting ready to have Dr. Parker take over in just a second. If you have a BMI of 35, you got to have at least one comorbidity. So you're now at home possibly going through your checklist. High blood pressure is one, high cholesterol, diabetes, obstructive sleep apnea, waist size over 40. But those first 4 are the ones that matter. If you got a BMI of 35 with one of those, you'll qualify for surgery, provided you got that coverage with your insurance company. If you got a BMI of 40 or above, comorbidities don't factor into this. You're also going to have to be healthy enough, and your surgeon, he's going to discuss this with you. Are you able to undergo a major operation? And I want to think about this. I had a guy that came in this last week, and I felt sorry for him. The guy was at his wit's end. And this is a man that had implanted a pacemaker. He had an implanted defibrillator. He can't get out and exercise due to the cardiac concerns that he has. And I've seen guys like this get cleared for surgery. You've got to be able to undergo a major operation, if you will. Failed attempts at weight loss. The behavioral therapists go into the world. Do we have any eating disorders? Are there alcohol problems? Are you smoking? Your doctor's going to check you for nicotine X number of hours before you go to surgery. Nicotine and healing in a gastric surgery environment is a very dangerous thing. You need to understand your risk. We do a great job of making sure that's taken care of. So are you a candidate? You're here tonight. You probably are a candidate. What's interesting, when we close this tonight, and Dr. Parker is going to come up here just in a minute, but I want to spend some seconds and kind of rehash this. We're here tonight because you're interested in your health. I'm concerned about your health span, not your lifespan. I want you to look on a piece of paper, the time and place of your choosing, put your age down on there. And then look at the people that you love and that you care about and go, am I going to be able to be here to be able to have some relationship with them in the next 5, 10, 15, 20, 25, 30, whatever that means? Look at that and say, if I don't take some action, I'm not going to be here for that, because this disease, obesity, can take 15 years off your life. Tonight, if you've heard nothing else that I've said, I'm looking to create an environment for you to be healthy. Obesity is a vicious gremlin. It does everything it can to reset points. It doesn't want you to lose weight. It's going to frustrate you. But in the face of a bariatric surgeon, we level the playing field and have a huge chance for success. All right. I hope my coughing has not been too much of a distraction. And I'm going to check off here now, and I'm going to hand this over to Dr. Parker. So here he comes.
Thanks. Oh, tough to follow, Greg. All right, well, hello, everybody. I'm Dr. Parker, one of the 2 bariatric surgeons we have at TMH, and I'm here to talk about surgical options, so let's get to it. I'm actually losing my screen. All right, so the surgical approaches that we have at TMH. So we have restrictive procedures, gastric bands. We don't really put those in anymore. They're pretty good for short-term weight loss, but not long-term weight control. And we end up taking them out most of the time and converting to a sleeve or bypass. And so if you do have a band, I would recommend working towards getting that out if you qualify. And then we have a sleeve. It's our most popular procedure. Probably 80% of patients nationally are getting a sleeve first because it has such good weight loss control. It's almost as good as the bypass nowadays with a good bariatric program. And its safety profile is about the same as a gallbladder surgery. So people do really well with the gastric sleeve. and is very safe and well tolerated. And then we have our malabsorptive procedures, which is basically the duodenal switch. And we still have that, fine print of offered selectively at TMH. We're starting to do more of these because patients who do have the appropriate anatomy and appropriate symptoms for a switch will lose more weight than just converting to a bypass. And so that is becoming a more popular option here at TMH. And then we have a combination surgery, which is the gastric bypass, which combines both the restrictive procedure, which is basically creating that little gastric pouch, and that's about 2 ounces in size, and then bypassing part of the bowel, so it decreases absorption of the foods. And so gastric bypass has been around since the 60s, and it's been called one of the most perfect surgeries by many people. We do love the gastric bypass, but we usually reserve this for patients who either have severe reflux or, insulin-dependent diabetes, or people who are just decide that they want to bypass instead of a sleeve. So how does it work? So this is the gastric bypass, and basically what it does is we create this gastric pouch and hook it up to your small bowel, which starts emptying food kind of down the road a little bit, and then once it gets about 100 centimeters down the road, it mixes with all the gastric juices, which then start to churn and start to mix and break down the food, and allows it to absorb with about half the small bowel. The sleeve is different. Basically, what we do is we remove about 50% of the stomach, which accounts for about 80% of the volume of the stomach. And what that does is it restricts the amount that you can eat. So basically, the esophagus just basically gets elongated into a smaller pouch down here at the bottom. And then also the fundus, which is the very top part of that removed stomach, what that does is it creates ghrelin. And you remember that in medical school is like growling, like stomach growling. So basically, ghrelin drives appetite. And so people who get a sleeve typically don't have the cravings for more food. Your satiety is improved, so you'll eat a third of your meals and you'll put the spoon down and think, I'm not hungry anymore. And so it works really well in that way. So this is the duodenal switch. As you can see, it's a lot more involved and complicated typically, and you can see right here, patients will already have a sleeve or will get a sleeve at the time of the switch. And then basically it's an elongated bypass. And so you have your digestive loop, and then you have your biliopancreatic loop, which is just a little bit longer. So the juices just mix a lot further down the road. And this is the highest success for weight loss. So for complications of the procedure, you can see this is the minor complications. Atelectasis is basically just your lungs aren't working to their full capacity right after surgery. You have to get up, move around, breathe deeper, cough, and clear all the secretions that you kind of pull during surgery. Reflux, and about 8 to 11% of patients will develop reflux. This is more so after gastric sleeves, is because we tighten the stomach. And if for any reason, let's say we miss a hiatal hernia, or just the increased pressure of the stomach causes things to want to go up instead of go down, the gastric acid will cause some reflux. That happens about 10% of the time. We do have options for managing that reflux. Conversion to a bypass is one of those options. But the anti-reflux medications alone typically knock this out. And then once you lose weight, about 70% of reflux actually controls itself because of the decreased pressure in the belly, pushing on your stomach, pushing that acid up. And these are very low percentages, but infections at any of the wound sites where we remove the stomach. Marginal ulcers, this is more bypass related, and those can be very tough to deal with. But if you follow the rules, no NSAIDs, no smoking, staying hydrated and nourished, typically you can avoid ulcers. There are some patients who get ulcers that are more of just an anatomical thing, which is a lot more frustrating to deal with because they're doing everything right, but that's far and few between. And then we have, hypertensive patients get hypertensive after surgery, but I will say that hypertension is one of the first things that resolves after bariatric surgery. Those patients come off of their antihypertensive medications within the first few weeks after surgery. And then DVT, which is just where you get blood clots, and that can happen after any surgery, and the rate is about 1% after any surgery. And so bariatric surgery is a surgery, and so you have DVT risks. These are the major complications, just because they require either return to OR or just continued monitoring in the hospital. So strictures, which can form over time from ulcers, typically more common after a bypass, can happen about 2% of the time. Hemorrhage, so basically having bleeding after surgery. Sometimes bleeding doesn't show up until after surgery. When we look, during the procedure, there won't be any blood. After the procedure, patients start bleeding again because their blood pressure goes up or they cough. That happens maybe 1% of the time. It's very rare. An anastomotic leak as well is, honestly, these are probably a little lower than this, but anastomotic leaks can happen about, less than 1% of the time. And that's just something that requires more surgery. Small bowel obstructions can happen rarely. The mortality risk is about 1 in 1,000. So highly unlikely to have any complications after bariatric surgery. So this is our TMH bariatric surgery data, and we actually have, and this is from 2023 to 2024, and so we're still working on the last years, and I'm excited to see those numbers because I'm sure they're improved. But the readmissions are low, 3%, reoperations less than 1%, so 1 in 200. Zero GI bleeding, bowel obstruction, DVTs, all of that is zero, mortality 0. And if you look at the national averages, they're not 0. So TMH is doing a very good job, myself and Dr. Gerard and our team, of preventing any of these issues. So long-term complications, protein malnutrition, this is more likely with gastric bypass. Some people do get nauseated after surgery. Some people do have trouble with taking fluids in. Staying hydrated, getting dehydrated can actually make the nausea worse, which just kind of snowballs. And then protein malnutrition down the line. Some people just have trouble keeping up their protein intake. You bypass some of the bowel that absorbs protein and they can get malnourished. We don't see this very often. And then vitamin deficiencies, more likely with gastric bypass, but can happen with both sleeve and bypass. And what we do is we have a accountability for taking our multivitamins. Any patient who gets bariatric surgery should take multivitamins because the stomach secretes a lot of these vitamins and the ones that kind of help with absorption of these vitamins. And we have certain recommended levels. Dietitians will go over that with you to make sure that you're not at risk for having vitamin deficiencies. To the expected weight loss, 3 months after surgery, we expect about 40% of excess body weight loss. And so, like Greg was saying earlier, 100 pounds overweight means 100 pounds of excess body weight. And so 40 pounds off in 3 months, 60 pounds off in 6 months, about 70 pounds in 12 months. And that's typically the average. But like I tell patients, good surgeon, good patient, that's motivated, goes out and works hard, can exceed those numbers and get back down to what we consider, an ideal body weight or patient's goal weight. And these numbers are fairly similar between both sleeve and gastric bypass. And like Greg talked about, losing weight can help your body function better, improve your ability to do things that are important to you. One of the first questions I'll ask patients is, how do you feel? Are you less tired? And it's always yes. Losing that weight, getting better sleep, obstructive sleep apnea resolves almost 100% of the time after bariatric surgery. Being able to sleep through the night without your CPAP really does wonders for your body, which then motivates you to go work out, and all of that just kind of goes hand in hand. We had one patient who said that her goal was to be able to walk on the beach. She couldn't walk in the sand because of all the weight on her ankles and her joints. Well, she's doing that now. She said she ran on the beach chasing her kids around like a few months ago, and that was less than a year after surgery. And it was all thanks to her having a positive outcome with a gastric bypass. And so results, we talked about sleep apnea resolving majority of the time. Cardiovascular disease improves. You come off of antihypertensive medications, off of cholesterol medications. Type 2 diabetes, a lot of patients will get off their diabetic medications and insulin. Asthma, COPD improves because of the decreased pressure on the lungs. Fatty liver disease improves, which is the most common cause of liver failure and cirrhosis now in the country. Polycystic ovarian syndrome can improve. And there have been many stories about people who were infertile who are actually able to have kids after having bariatric surgery and weight loss. And then obviously osteoarthritis with less weight on the joints. So surgery can help change your life. It improves or resolves obesity-related illnesses, about a 90% reduction in 5-year mortality, and improves quality of life in 95% of the patients. I think there's a study that says that cardiovascular-related issues, patients are living an average of 5 years longer after having bariatric surgery. So remember, a surgery is a tool that requires your strong commitment to a lifestyle change and lifetime of follow-up. And don't worry, Greg will make sure that you don't slip up. Common aspects of bariatric surgery, it's all done minimally invasively. We say laparoscopically or robotically, but now it's basically all robotically. We do it all the same way, standardized. Myself and Gerard do the exact same technique, which means that even when myself or Dr. Gerard are out of town, the surgeon who's covering for his patients also does things the exact same way. It really helps with outcomes and making sure people get consistent, awesome care. All these surgeries are done in under 2 hours. That's baseline. Most of them are under 1 hour. The sleeves, some bypasses actually are under an hour. The hospital stays between 1 and 2 nights, and say that 99% of patients go home on hospital day 1, and are back to work within a week or two, just once they get into that routine of creating portion control and taking recovering from surgery. Pain's usually not too bad. Honestly, I'm happy to give patients time to recover, because it's not just a physical recovery, but emotional and mental recovery as well. So insurance information, and this is something that we have people that can help you with, finding out if your policy covers surgery. Most of the policies, like Greg mentioned, require BMI greater than 40 or greater than 35 with comorbidities. There needs to be a documented history of medical weight loss attempts most of the time, 3 to 6 months at least. A 5-year history of weights, and that's just going to a primary care doctor. That's not for every insurance company. If you have any questions about these, always call your insurance company and ask them if you're qualified. Psych evaluation is very important, especially to kind of discuss and talk about, binge eating disorders and things like that, or bipolar, antidepressant. All of that is something important to address when you're going through the stress of preoperative and postoperative for any surgery. And nutrition counseling, we have great nutritionists here to help you as well. And so we'll help walk through the process, review plan requirements, submit documentation. All of that will be done by our team. And if you have any questions or concerns, obviously the most important part of the team is Angie, and she'll help you get plugged in. And there she is.
Thank you, Dr. Parker. Please take down my name and number if you have any further questions. We do have some in the Q&A that we can go ahead and address. We have here, my daughter is 14, weighing 255 now. I've had the surgery 3 years ago. Love my success. What's the earliest age to get to talk to the dietitian or therapy? Congratulations on your success. And unfortunately, our program providers, we don't see patients under the age of 18, but I don't think that conversation can be done early enough. So we highly recommend reaching out to your pediatrician or physician to get a referral for that. And if you need help looking for resources, I'm happy to help get you plugged in with a program that takes kids.
That's super important. There are programs who even offer bariatric surgery as young as 15 years old. So, obviously that's not the first goal, surgery. Lifestyle changes is the first goal, but getting involved in a program is definitely good for accountability.
Thank you for that. Our next question is, do you all offer suture sculpt, an FDA-approved groundbreaking non-invasive endoscopic sleeves procedure that helps you lose weight without incisions or permanent alterations? If not, in the future, will this be offered?
That is a good question. We know the reps for endoscopic sleeve gastrectomy, and myself and Dr. Gerard do advanced endoscopy. And one thing that I worry about with that procedure, and companies that have a lot of money to market things make things sound really swell. But when I look at the science of it, I worry that suturing the stomach from the inside, not necessarily, it doesn't change it permanently, but what it does is it leaves that aspect of the stomach that makes you hungry. And I worry that patients are not going to be able to satisfy their appetite after getting a procedure like that, and they're going to be constantly hungry. So for that reason, I have not been inclined to offer those procedures until we have more data about endoscopic sleeve gastrectomy. I think there are about 5,000 or 6,000 of those done per year in the country, whereas 200 to 300,000 sleeves and bypasses. So I think a lot of at least the trained bariatric surgeons are avoiding it at this time because we're worried about making patients miserable after they get it done. And if data comes out that changes that for me, I'd obviously think that anything good for patients is something that I want to help out with.
And then we have here, I had the sleeve about 10 years ago. What would be the best option for me?
So that's something that I'd like to, have you come see us for in clinic. As far as there are a few things to consider regarding that. Current symptoms, reflux. If it's just for excess weight loss, that's something that we could convert, do switch or convert to a bypass. It really requires like a conversation, about goals and symptoms, and I think that'd probably be a better in-clinic discussion.
Does anyone else have any questions? We can leave it open for oh, here we go. Can this class count towards our initial appointment? It's not. That you would still need a consultation with the surgeon, but we do like for you to view a webinar or a seminar video prior to your appointment, but still have to have that one-on-one for a surgical consult. Sorry. If there's not any more questions, if you think of something after the webinar and you want to reach out, please feel free to email me at the email address below. Give me a call if you would like to schedule a consultation. I can also help you with that. You guys be on the lookout for an email. Someone's going to be a winner of a Publix gift card. I guess that's going to end our night.
All right,
Thank
thanks
you all for joining us. Oh, here we got one more question. We got a few more minutes. What about HRT?
Greg, you want to take this one?
Hormone replacement therapy. Interesting idea. Typically speaking, that's going to be left in the domain of the OBGYN. If they come up with a series of tests and can come up and at least point to some deficiencies, then certainly some really, really competent people here in Tallahassee that could address that. We don't do that. Now, if they get you squared away with your hormone, whatever that happens to be, and the causes that they investigate and come up with some answers, we'd be more than happy to take you on afterwards once that's been achieved. But that's way out of the scope of our domain here. Great question, though.
You said it so much better than I actually have.
I had a lap band inserted about 12 years ago. Should it be removed?
If it works for you, then it works for you. I would say that, I don't anticipate lap band complications. And I do lap band adjustments. I have some patients who just absolutely love their lap band. But, lap bands can cause a magnitude of problems. If the weight was regained, if reflux has developed, if you have trouble swallowing foods, these are things that, would make me want to consider helping remove a lap band. But if you're happy and you just have a lap band and it works for you and it fits with your way of life, then I support it. I think that lap bands can be good and they have their place. But usually when the patient starts seeing me for lap bands, that's usually what I hear. And that's when we usually starting the conversation of conversion to even a sleeve. We used to just take them out and just do lap band to bypass, but I think sleeves are decent options for patients who have lap bands in the appropriate anatomy.
The same person that asked that question, I have regained all of my weight and now have different medical issues.
And that was kind of what I was answering with that last question. Was, it's and problem with lap bands, and we can go into it more when you see me, but people kind of learned, lap bands restrict what you can bring in, but then you still have, just like with the appetite, you still have your entire stomach. Just like if you do an endoscopic sleeve, you still remain hungry and you got to satisfy that. And so getting calories, if you can't eat them, then you drink them. And then we're drinking things that are just carbs and maybe a protein shake here and there. But that's why people start to gain those, that weight back.
I have one that says, can I go ahead and schedule a consultation now? I can go ahead and get your name and information, and I can probably do that first thing in the morning if that would work. I don't have access to my schedule right now, but I could do it first thing tomorrow. I've got your name and information. I'll reach out, or if you want to give me a call. Will you please go over the qualifications for surgery one more time?
Let's see. Here we go. I'll just leave that there so you can read them. But basically, it's all based on BMI calculations, height and weight, and then over 35 with comorbidities or over 40 without comorbidities. And it all depends on insurance policy. And that's something that we can help to kind of dig into further.
I have a statement here. Thank you for your time. I'm glad I made it tonight. We are so glad you made it tonight as well. Thank you. And I really love this question. Dr. Parker, I can't wait for you to answer this. Will this surgery affect my fertility or any future pregnancy?
We ask that patients don't get pregnant within a year typically. Sometimes some programs will say 2. We usually ask for a year of not getting pregnant after surgery. But in terms of, fertility, there's no data to suggest that it would decrease fertility. But in obesity, sometimes patients lose fertility just because of the disease of obesity itself and polycystic ovarian syndrome and all that. And so I would expect that if anything, it would improve fertility.
Okay. Well, I think that's the end of our webinar. Again, please feel free to reach out. Ms. Wida, I'll get with you about scheduling a consult. I'll send out our webinar Publix gift card winner. And thank you all so much for joining us tonight. We look forward to meeting you guys.
Thanks, Sean.